Hey guys, am I audible, visible? If I'm audible, let me know. A very good evening. Good evening, guys. Hope I'm audible and visible. Okay, good afternoon, Abbas. Good afternoon, Abbas. Fine. Perfect, guys. Hope I'm audible and visible. So, this is the last Farre of pathology. I hope that some of your colleges must have had the pathology exam already over, or it'll be in the very near future, right? I'm very good when I hope you're doing good as well. Hi, X. Good evening. Good afternoon or good evening, wherever it is going to fall us, right? So, what we're going to do today is go through quickly regarding few concepts of immunology. A little bit of questions in genetics because I'm sure you know that there are very specific things which can be asked in genetics. Inflammation, we'll run a quick run through because inflammation might not be just required for understanding and writing this. You can also conceptualize in writing other disorders of inflammation throughout the body and organ system, right? And then we'll also, if time permits, we'll look at shock because I'm betting on general pathology. One long answer question, most probably it will be related to shock, right? So let's see, that's mostly like septic shock, how to organize structure or format of question, fine? So if you're ready for the game, as usual, let's start with a smile. So first thing, amyloid is something which is very important with respect to pathology. Second prof has a very unique thing, like it can come as a 2-mark question. They can ask about Congo red and an MCQ, or the different types of AL, AQ and everything in your one-liner as well, fine? Okay, so amyloid, as usual, the structure for every general pathology start with a very tiny definition, whatever in your own words, need not be from the textbooks at all, fine? It's a condition associated with an extracellular and an acellular deposit of fibrillar protein which is responsible for tissue damage and a functional compromise. Fine, that's what amyloid is, right? Amyloid is nothing but an extracellular proteinaceous substance, right? It's a protein. It's actually a malformed protein. It's not proper protein. It's nothing but a beta pleated sheets. That's why we also call them a fibrillar protein, right? Fibrillar non-branching fibrils is the classical definition of amyloid, right? So first, once you know amyloid, write a brief description about two important things in amyloid about the pathogenesis. Pathogenesis of amyloid is very, very simple. One is excess production of a normal protein, where the protein is completely normal, structurally, mutation-wise, gene is completely normal, or I have a reduced production of an abnormal protein. Can anyone give me one example for each? I have an abnormal or a mutated protein and has been normally produced. It's an accumulation of a not reduced production or an accumulation of an abnormal protein, right? A normal protein could be as simple as your light chain, AL amyloidosis, right? Serum amyloid A protein and chronic inflammation related amyloidosis, right? All of them are not normal protein produced in excess. AL, A, everything, right? ATTR. If the ATTR is very, very unique. It can fall in both. Senile systemic amyloidosis, ATTR is a normal protein. At the same time, we have familial amyloidotic polyneuropathy. ATTR can be mutated as well. Okay. AA can also be mutated as well. For example, in familial Mediterranean fever, right? Okay. In familial Mediterranean fever, in familial neuropathies, we can have mutated parts, right? So I can have excess production of a normal protein or a normal production of an abnormal protein, right? This is what is going to cause the protein accumulation. Then the types of amyloid based on the structure of amyloid, right? Tell me the diseases, fastest finger first, starting from the easiest one. That's the most common cause of amyloid as well. That's your diseases, myeloma. See, actually general pathology, after finishing systemic and hematology, it's much comfortable. We already have read this in different places, right? Anything which is chronic inflammation related. Could be in rheumatoid arthritis, could be a tuberculosis, could be in familial Mediterranean fever in mutated, everything, right? Perfect. A beta 2M, where do you see A beta 2 amyloid? Beta 2 microglobin will be seen in case of an chronic hemodialysis, because in hemodialysis, when the machine is going to do the function of the kidney, might not be able to completely remove the beta 2 microglobin, so it kind of gets deposited. Great X, right? ATTR, like I said, two things. It could be in senile systemic amyloidosis, where it's a normal ATTR, but the patient is living for like say 90-95 years, accumulates. At the same time, I can have familial amyloidotic polyneuropathy, right? You can have familial polyneuropathies where I'll have a mutated ATTR that also can get deposited, right? ACAL, CAL stands for these three. There's another way to describe them as well. We call them a localized amyloidosis, because seen predominantly in that organ. CAL stands for perfect, medullary carcinoma thyroid, only in thyroid. A beta, Alzheimer's, only in brain. AAPP, in pancreas or insulinoma, type 2 diabetes, only in pancreas, right? In other words, I can classify these as systemic amyloidosis, where myeloma, the light chain can go throughout the body, right? So here Yes, you're absolutely right. You can have in medullary carcinoma of thyroid, right? Perfect. You have this in Alzheimer's disease, A beta 42 or A beta, anything was enough. AIAPP is seen in pancreas, two conditions. It's due to insulin's byproduct. So I can have a tumor of insulin, insulinoma, or a type 2 diabetes mellitus. Especially in the Viva, they might ask you this, not type 1, it's type 2. Please do remember them, right? So this is about the places where I see them amyloid. Short answer, just name them. Long answer, right. Right. Why it is type 2 diabetes mellitus? Type 2 has excess production of insulin. Whenever there's an excess production of insulin, the breakdown product will be also be in excess. That's why it gets deposited. Fine. We know the thing. Myeloma. Just write myeloma if it's a short answer. If it's a long answer, myeloma produces more light chain because of the neoplastic proliferation, so it gets deposited, right? You can easily expand the question. At the same time, you can easily restrict the question as well, fine? So once we know what are the types, then I want to write the symptoms or the organ finding. Whenever I write the organ, more or less the symptom will be right? Good evening. Fine. So kidney is the most common site of amyloidosis. Yes, obviously, you will definitely have the patient with a renal failure. In kidney, when I take the gross finding, it could either be normal or increased in size. That's dependent on the stage of amyloid, right? Very tiny amount, normal size. It can also be increased. Extremes of later stages, since amyloid deposits around the blood vessels, what will happen? It will shrink, right? Extremely later conditions, terminal stages, it might shrink, right? Spleen, what are two types of amyloid deposits in spleen? You guys know that. What are they? We have two different types. We have your sago spleen and we have your lardaceous spleen. Lardaceous is lake-like. Sago is dots. Sago, pakka might be in the Viva, right? Sago is then your involvement of amyloid in the white pulp, and lardaceous is involvement of amyloid in the red pulp. By default, both of them will have splenomegaly. Clinically, the patients might have a splenomegaly or an organomegaly, right? Liver, space of Deci. Again, you can have a hepatomegaly, and the deposition will be in the space of Deci, right? Perfect. Why in white pulp like a dot? Because white pulp is nothing but periarteriolar lymphoid sheath. So around the blood vessel, amyloid will get deposited by default, right? Heart is the most common cause of death in amyloid because cardiac amyloid can cause restrictive cardiomyopathy and conduction defects, right? We read in restrictive cardiomyopathy in your CVS chapter, this can cause, and also it can cause conduction defects. And kidney, I can change the kidney easily, or dialysis. Heart is a bit difficult to change. And not that heart transplant is not possible, but it's a bit rare compared to a renal transplant. That's why it's the most common cause of death in amyloid, fine? Tongue, the only finding you will have here is macroglossia. So if amyloid is going to come in a long answer, think about macroglossia, fine? Hi Arjun, just taking bits and pieces of different topics, some from immuno, some from one or two from genetics, one or two from the first two chapters. Let me know if you want anything at the end, we'll add that as well, okay? Fine. So diagnosis, clinical, if there is a history which is going to cause amyloid, yes, that will definitely help us. Obviously, that's the first point, right? Apart from that, I need a biopsy or a tissue-based diagnosis, right? The site of biopsy in a localized amyloidosis, fine. No, Rishank. Maybe for your thing, I am sure that you will go to third year. Third year also pathology is not going to leave you. Fourth year also pathology is not going to leave you. We'll have more classes further, right? Okay. With a localized amyloidosis, you need to take the biopsy of the organ, right? And in case of a generalized amyloidosis, the best site is fine. And also I'll try if possible I can take a Farre for practical exams, not so sure, right? For generalized amyloidosis, it's preferred to be an abdomen pad of fat. That's a preferred site for amyloid, or I can take an oral cavity gingival biopsy or a rectal biopsy, but abdominal pad of fat is preferred. In abdominal pad of fat, when you take a biopsy, in a normal light microscopy, what will you see? And I want you guys to fill up the blanks. What's the stain? After doing the stain, what's the color of the stain amyloid in normal light microscopy? After the stain, what's the color of the amyloid in polarized light? All these might be required. What's a normal color in H&E? Normal color is pink, right? It's pink, extracellular, acellular, amorphous deposit. Write everything, right? It's pink, it's protein, right? That's all right. It has to be an extracellular. It has to be an acellular. No particular shape, amorphous, right? Amorphous deposit. What's the stain? You shouldn't miss this, right? Congo red is a stain. After applying Congo red, the color changes. It becomes a salmon pink in color. Salmon pink is an orange shade of a pink. After that, yeah, acridine orange. There are, see, thioflavin. There are many stains, crystal violet, gentian violet. Many of them, even including PAS, will highlight them. It's a protein, right? It'll highlight, right? But these stain for me is Congo red. Apart from that, you can go for your polarized light. You can see this image, apple green birefringence. Fine, that's the perfect or the final thing for me to confirm it's an amyloid deposit, right? If it's a long answer or short answer, just to conclude, the best test to identify the amyloid is you have an X-ray crystallography, because X-ray crystallography tells me the structure of the protein. That's the best test to pick up amyloid. Fine. Yes, Maggie, I saw the question. That was a pretty decent paper. I hope you must have done very well, Maggie. Fine. Okay, that's in short with amyloid. There's a possibility the question of amyloid can come. If it comes, do very well. Fine. Okay, let's go to the next one a little bit. Hypersensitivity reaction, right? Hypersensitivity, whatever you're going to read this, it might help here, or it might help in a question of asthma, or it might help in a question of tuberculosis, type 4 is TB, or it might help a question of SLE, lupus nephritis, type 3, or it may help in a question of, let's say, Hashimoto's, any of the type 2 hypersensitivity disorder, autoimmune hemolytic anemia, anything, right? So this is a base. Like that, we can definitely easily apply to almost everything here, right? So there are 4 different types of hypersensitivity. If it comes in a long answer, write in short about everything. I don't think it might come in a long answer. Most likely it will be in a short answer, right? About allergy. So this is IgE mediated. Antigen antibody is the second one. Predominantly IgG. I can have IgM and IgA as well. Circulating immune complex is antigen antibody complex in circulation or sometimes planted. This is the only thing which is T cell mediated or delayed hypersensitive response. Fine. Perfect, Maggie. Okay. Let's go to the each and everything little bit in short, right? So type 1 hypersensitivity. See, if you're writing an exam, I would look for a few keywords. What are the keywords which comes to your mind with respect to type 1 hypersensitivity? If you are an examiner, you want these things. Can anyone tell me? Let's go. Let's take it from you. Let's start it from you. Type 1 is an anything which comes to your mind. Whatever comes to your mind. Immediate hypersensitivity. Great. That's great as friend. Anything else apart from that? Great, Maggie. Great. I hope you wrote that pernicious anemia thing, right? That also you added because of atrophic gastritis was there in your long answer, right? IgE, allergy mediated, great. See, those are exact points we look for. Few more things. Type 1 hypersensitivity almost always has 2 phases. What are they, right? Type 1 hypersensitivity is an immediate response, right? That's very, very important, okay? Immediate hypersensitivity in a previously sensitized individual. This is very, very, very important, right? It has to have a previous phase of sensitization. That has to be there, right? Perfect, right? Sensitization, re-exposure, only then it can cause type 1 hypersensitivity. There are exceptions. Can anyone tell me what's the exception? Exception where there's no sensitization phase. The disease is called as, we call it anaphylaxis. Sure, Ishank. Just tell me in the last, I'll definitely tell you, right? It's anaphylaxis where the hypersensitive reaction will be very, very intense even after the first exposure. That might be catastrophic. We might even lose the patient, right? So when I talk about hypersensitivity, you have to talk about the allergen or about the etiology, right? Allergen can be anything, right? Any allergen what comes to your mind, but please don't forget the important ones: pollen, dust. Pollen and dust are the predominantly common allergen. Milk can also be an allergen. There are multiple allergens in the body. You can write anything, right? So then what I write is the sensitization phase. What happens in sensitization phase? It will be great if you can draw a diagram like this, which is there in the Robbins as well. The first exposure via the respiratory tract goes and will attract your antigen presenting cells that will present the antigen to the T lymphocytes. The most important thing is which type of lineage will it change to? T lymphocytes. Let's take pollen grains. Goes there, antigen presenting cells picks the pollen grain, presents into your CD4 T cells, and the CD4 T cell will bind to the pollen grain via the MHC2 complex, and it will go into Th2 type. That's very, very important. It has to be Th2 type because Th2 type is involved in the allergic phase, right? So Th2 type will secrete multiple interleukins, IL-4, IL-5, right? And interleukin 13. If you know, write everything. Fine. Okay. Hi, Abhishek. Right? If you know what is the all the interleukin, write everything. At least name them. One helps in production of IgE. One attracts the eosinophil. One causes epithelial damage. Epithelium is the longest term, right? So this causes epithelial damage, right? It attracts eosinophils, and this helps in the production of immunoglobulin E, right? Okay. Do well, X, you will owe everything to your patients in future. Fine. Okay. So that's what's going to happen here. So once this does it, it's a very, very simple thing. Let's take one more page. Sorry. Fine. So once the Th2 responds that, this produces IgE. The IgE, it will go and bind to the receptors or the Fc receptors on which cell? On the mast cell. So this is the sensitization phase. It stops there, right? After that happens your what? Re-exposure, right? So re-exposure, once re-exposure happens, it's a very, very simple thing. Second time exposure, second time a pollen grain comes, draw a mast cell. Mast cell is nothing but tissue basophil, so please do draw granules because the first step is degranulation, right? And need to happen, right? So IgE, the pollen binds to the already existing IgE on the surface of mast cells, which results in the degranulation of the mast cells, right? Perfect. So once degranulation happens, talk about any of the inflammatory mediator you know, but one is must. Which inflammatory mediator has the richest source in mast cell? Never ever forget that guy, histamine. You cannot forget because pharmacology is over. Antihistaminics is the first line of treatment what I give for allergic response, right? You can write histamine, you can write leukotrienes, you can write whatever it comes to your mind. But histamine has to be must. Platelet activating factor. There are many things which comes, but at least write histamine, right? That has to be there. Histamine will be there. Your proteases will be there, right? And your arachidonic acid derivatives will be there, right? All these causes your immediate phase response. The immediate phase response will be same as an acute inflammation, which is vasodilatation and increase in vascular permeability. If it's the throat, mucus secretion and blockage, right? Then, and all these arachidonic acid derivatives, primarily leukotriene B4 and other chemoattractant will attract more WBCs, especially eosinophil here, which will cause the late phase response. Fine. So that's what is going to happen in type 1 hypersensitivity. An immediate response, after some time, you'll have a late phase response because of cytokines and other things which is being secreted. Fine. Okay. Done. This is in short about type 1 hypersensitivity. Make it short and sweet. For a 5-mark answer, don't write in excess. You know asthma. I'm not denying that. Just because you know asthma, don't bring it there. 5 marks, half a mark for definition, half a mark for allergen, 1 mark for these, right? And few marks for examples. That's more than enough. More you write doesn't mean that you'll be given more marks. And if you want an integration, write about mast cell stabilizer, sodium chrome glycate, write about antihistaminics, write about leukotriene antagonist. You can put that in the diagram and write. I can block in this way, right? Examples. Anaphylaxis is an immediate thing with esophagitis. Fine. All these are examples of type 1 hypersensitivity. You can write a little bit more, but 4-5 examples are more than enough. That's for type 1. Fine. Then let's go to type 2. What's the type of type 2 hypersensitivity? What's the basic step? It's a hypersensitivity due to antigen antibody reaction, right? That's a type 2 hypersensitivity, right? So antigen is either present on the surface of a cell or present on a surface, or it could be an altered function without a destruction, right? We read about 3 different types of type 2 hypersensitivity. Type 2 hypersensitivity is an antigen antibody reaction where the antigen can be on the surface of cell, okay, on the surface of a cell, which can be engulfed, or on the surface which cannot be engulfed, cannot be phagocytized. Like Ipsda said, it could be against a receptor. This is not engulfment or destruction. This is dysfunction. I just alter the function. It goes and sits there, doesn't let the acetylcholine causing your myasthenia gravis, or activates receptor causing Graves' disease. Three different types, three different outcomes. I want these three types. In everything, this has to be there. See, tell your juniors, Robbins is a very easy book to revise, because if you read Robbins, there's nothing. It's very, very simple, right? So you have the complement there. You have the phagocyte or the macrophage coming, engulfing and destroying. Simple cell-mediated phagocytosis. That's all. Because complement proteins are opsonizing features. Your macrophage will have the Fc receptor or the complement receptor, will identify them, will engulf them, right? So this is on a free cell. What are the examples of diseases where you have the antigen on the surface or on the free cell? Free cell means it has to be floating. Autoimmune hemolytic anemia, ITP. These are two things. Erythroblastosis fetalis. It should be blood cells, predominantly blood related. That's examples here. If you look at the examples, what all comes under that? You'll have your autoimmune hemolytic anemia, autoimmune thrombocytopenia, and also we don't have that. We'll write that as well. We'll have your erythroblastosis fetalis. Fine. That also will be there, right? These three are classical examples of where it's been engulfed, right? One is enough, but three would be great, right? Next part is on the surface. It is complement Fc receptor mediated inflammation, where the antigen is on the surface, so my antibody is stuck there. My macrophage cannot engulf it, so it gets frustrated and releases the granule, causes inflammation. You'll be degranulating, and it causes lots of inflammation. It's on the surface. Example? Anything example on surface? We did read about a lot of them. Vasculitis, right? Glomerulonephritis, rheumatic fever, everything is on the surface. I cannot eat this, I cannot eat this, I cannot eat a collagen, right? All these are on the surface. These are due to antibodies on the surface, receptor mediated inflammations ka example. Fine. All are classical examples of receptor mediated inflammation. Third is dysfunction. It's not destruction, it's dysfunction. Hashimoto's also, fine. Third is your dysfunction, where the antibody binds to the receptor and either blocks it or promotes it. That's all. It either blocks, example for blocking is myasthenia gravis, or activates. Example for activating receptor? Perfect. It's your Graves' disease, right? Previously, we called them a type 5 hypersensitivity, this dysfunction part, but later on we found that it's also antibody mediated. Let's put into type 2 hypersensitivity itself, right? So this is the basics for all of the type 2 hypersensitivity. You can apply this. See, when a question comes on Graves, take this part, put it there. Question on Hashimoto, autoimmune hemolytic anemia, any autoimmune disorder which is mentioned here, all of them in the pathogenesis, you can write type 2 hypersensitivity. Fine, clear? Done. Okay, that's about type 2. It's a very, very simple one. Must to read, where I can use it for systemic pathology, not for general pathology alone, right? Third is type 3. Type 3 is circulating immune complex, right? Circulating immune complex, the prototype is SLE. But we must have read the prototype as in the Robbins as giving a horse serum and how it produces the antibody, right? So type 3 hypersensitivity pathogenesis, 3 simple steps. The 3 steps should be elaborated if it's a long answer, otherwise write in 2-3 points, short answer. The first is formation of immune complex, right? For an example, you given horse serum to a patient, like in the form of an antivenom. You give it, you inject it, right? So that will form an antigen is there. There's a horse serum, antibody is there, and this is bound. There's an antigen antibody complex which is formed in the circulation. First step. The second step is perfect. Second step is it has to get deposited. The immune complex will get deposited, and this is where the pathogens of SLE matters. The deposition always happens in tiny vessels. The deposition always happens when there's a sluggish flow. That's or a branching. That's where almost deposition happens, right? Once the deposition happens on the surface of an endothelium, what will happen? Inflammation injury. This same antigen antibody complex. This third part now, it's actually like this. Same antigen antibody complex. Macrophage will come and stick to it. WC will come and stick to it. Cannot engulf the surface. Degranulates, causes inflammation. Same complement, same WBC, same chemo attractor, right? So third part is simple. It's going to attract complements. It'll have more and more in WBC. Primarily, it causes vasculitis. Type 3 hypersensitivity is primarily vascularity. That's why the term fibrinal necrosis is very, very important. It will have fibrinal necrosis by default. We cannot help it, right? So these are the three simple steps. The terms are important. The headings are important. Formation of immune complex, deposition of immune complex, and inflammation, injury or vasculitis and tissue damage. Fine. Examples. Neha said serum sickness. By default, serum sickness is the prototype. We had a localized serum sickness. Can anyone give this name? Because in a Viva, when you say serum sickness, the next question is, what's a localized reaction called as? It is Arthur's reaction, right? Serum sickness was the prototype. This is a localized form of serum sickness where you have an arthritis or an arthralgia, right? SLE is the modern day biggest disease of type 3 hypersensitivity. Fine. You can have post-streptococcal glomerulonephritis, though this will come under planted antigen. Write this. In post-streptococcal glomerulonephritis, it is not a circulating immune complex. It's a planted antigen or a planted immune complex. Fine. Pan reactive arthritis, again this is an vasculitis, where in pan the antigen antibody complex is that of an hepatitis related. Obviously, because hepatitis is a trigger here, right? Reactive arthritis, any bacteria, and serum sickness we don't have these days because we have moved everything to recombinant vaccines and recombinant vials, right? If we use an horse serum as an antivenom, still we can have serum sickness there, right? So that's about the few examples of your type 3 hypersensitivity, right? Let's go to the last guy, type 4 hypersensitivity reaction. What's the unique thing about type 4? Type 4 is two things. It is cell mediated, T cell mediated, and it is delayed. It is not quick, it is delayed, right? Other three might be a bit quicker. This is definitely very, very delayed hypersensitivity response, right? Delay in sense, it will easily take a day or two, minimum a day or two. If you remember Mantos reaction, easily day or two. All of these I'll be able to appreciate only after a day or two, right? It's a delayed hypersensitivity response. We do have two types of delayed hypersensitivity response here. One is CD4 mediated, one is CD8 mediated. CD8 we don't emphasize much, but if it's a long answer, I want you to emphasize. CD8 mediated means the same antigen. The only difference here is it will be, the destruction will be mediated by cytotoxicity. We call it cell mediated cytotoxicity, and we know how it gets destroyed by two guys, perforin and granzyme. Fine. CD4 we know. CD4 is the exact pathogenesis of your TB or your granuloma formation. You can write the exact pathogenesis. That's more than enough, right? T lymphocyte, antigen presenting cells, has MHC2 complex, T cell receptor binds to it, right? It becomes sensitized. Which pathway? TH1, TH2 or TH17? This place. The predominant outcome of CD4 here is TH1, but there's a possibility TH17 can also happen, right? That I want you to mention. Here in CD4, the maximum outcome is based on TH1 activation, which actually results in a granuloma, right? And there is a possibility it can also be TH17 activation. If that happens, you might end up in having an acute on chronic inflammation. So you'll have abscesses in chronic inflammation. Which of the GI disorder has abscess, though it's in chronic inflammatory disorder? Cryptabscess, ulcerative colitis, classical example. There's a chronic inflammatory disorder of the skin, which also has abscess. Silvery skin, psoriasis, right? Pottier's microabscess, that also is a classical. Monroe's microabscess, that's also the classical example of TH17, right? It's acute on chronic inflammation, and this is granuloma. So granuloma formation, simple. Sensitized lymphocyte becomes TH1 type. TH1 type secretes interferon gamma. We'll look at the granuloma very soon in chronic inflammation. The same way it becomes activated macrophages, it will form giant cells and ends up having a granuloma. That's the basic premise of TH1 related type 4 hypersensitivity reactions, right? Type 4 hypersensitivity is a base for quite a few type 2 reactions, because type 4 comes, T cell destroys, new antigen is formed, resistant type 2. Pernicious anemia, same combination. Hashimoto, same combination. There are combinations of type 4 as well as type 2 hypersensitivity reaction, right? Few examples as per Robbins: rheumatoid arthritis, multiple sclerosis, type 1 diabetes, inflammatory bowel disease, like I said, it'll have TH17 and TH1. Psoriasis, again, it'll have TH17 and TH1. Fine. Remember this, don't forget. This can be an MCQ as well. Contact hypersensitivity is type 4. Generally, whenever we think about allergy or contact, what's the first thing comes to your mind? Type 1, right? Prashant, I told you that immune complex has to be type 2, but it's been talked as type 3 hypersensitivity because of a bit of a complex pathogenesis. Like I said, as of now, still Robbins keeps them as type 3. We'll keep them as type 3. It's still in discussion in the medical community. If it changes, I'll let you know for sure, Rishank. Fine. Rishank, Hashimoto is there in type 2 only. I'll go to type 2. Hashimoto is there in type 2. Sorry, Graves is there in type 2, Punish is there in type 2, Hashimoto will be there in type 2. But the only difference, so the difference is simple. Type 4 and type 2 are actually interrelated. So when I say a T cell destroys thyroid, can I say it will cause antibody or neoantigen? Yes, it will cause a neoantigen. Once it produces a neoantigen, can the B cell produce autoantibody to the neoantigen? It will. So T cell destroying thyroid produces a neoantigen of thyroid peroxidase, produce an autoantibody. It results in this. A T cell destroying my gastric parenchyma produces antibody to your intrinsic factor, becomes pernicious anemia. So most of the pathogenesis will start from a T cell, will end up in a B cell, and will be propagated by B cell. That's how it is, right? Quite a few of them, be it Hashimoto, be it your pernicious anemia, it's just same outline. Fine. Okay, perfect. That's about hypersensitive responses. Fine. Fine. I'm sure you know about first chapter, right? Let's do one thing. Instead of going to necrosis now, I'll talk about necrosis apoptosis also. But I'm going to ask you simple questions. Let's see how far you remember the first chapter. Let's quickly revise it, not by writing, by talking. How many of you are ready for it? If you say yes, let's do that. Same, Rishank. Yes, perfect. So put your pens down if you're writing, or just keep your fingers on your keypad. First question. Which is pathological form of cell death? Necrosis, apoptosis? By default, necrosis is the, you can just type the first letter NA, that's more than enough for me, right? Necrosis is the pathological form of cell death, right? Tell me 3 characteristic findings of necrosis. Microscopy, gross, anything. Necrosis will have cell swelling or cell shrinkage. Will have cell swelling. Necrosis will have inflammation, yes or no? Will have inflammation. Necrosis, there will be cell membrane damage, yes or no? Will have cell membrane damage, absolutely right. What do you think is the most common cause of cell death or most common cause of necrosis? It's hypoxia. Ischemia is the most common cause, right? So if you want to write the pathogenesis of necrosis, it has to start with hypoxia. When there is hypoxia or an ischemia, what will happen to ATP? ATP will reduce. What's the next step? Which pump will stop functioning? There's one guy, right from the first year till your last year, it will make you suffer. Sodium, potassium, ATPase will stop functioning. If sodium, potassium, ATPase stops functioning, what will happen to the cell? Water will enter inside, homeostasis will be disturbed, the cell will become swollen. So we call it the first morphological phase of cell injury, cell swelling. Some places like liver, the function alters, so I can have fatty change as well. So when the cell swells, the intracellular organelles also swell. Swelling of the endoplasmic reticulum, detachment of the ribosomes, all these also will happen. Few light amorphous densities in the mitochondria will happen. At one point of time, what happens is the permeability, there will be a bleb formation in the cell membrane, the permeability alters. When the permeability alters, can anyone comment on the enzymes which will come inside? There are 3 enzymes important for me. When the permeability alters, phospholipase comes outside, fine. Like cell bleb formation, Rishank, the mitochondria also will swell, mitochondria also will have a bleb formation, right? X, vacuolar degeneration and your ballooning degeneration is same as cell swelling. It is used in different places. Vacuolar used in primarily in kidney, ballooning used primarily in your hepatocyte, that's all. Proteases come inside, phospholipases come inside, and nuclease come inside. Phospholipase will cause rupture. The hallmark of irreversible cylinder of necrosis, cell membrane damage. Protease will destroy the protein. That's why it becomes dark pink in color. Nuclease will cause, someone told me already, your pycnosis, condensation, karyorrhexis, breaking, karyolysis, destruction. So finally, what I'll have is destroyed protein, no nucleus, ruptured cell membrane. Who will come and clean this, guys? Your macrophage. That's the pathogens of entire necrosis. That's how almost always necrosis happens, right? That's it. Clear? Perfect? Done. Because of the rupture in cell membrane, all the intracellular contents will come outside. So I can use troponin I, troponin T to diagnose, AST, ALT to diagnose. Whenever enzyme increases, by default, I'm thinking of a necrosis going on, right? Okay, perfect. This is about necrosis. Can anyone tell me the types of necrosis? LDH, everything. Types of necrosis. You comment on the type of necrosis. I'll write about simply about the pathogens of necrosis. The most common cause by default is reduced oxygen or reduced blood, reduced ATP. That will stop my sodium potassium ATPase. That will make a normal cell, swollen cell. Only one. We want more of them. CLFF. We're too lazy now. It's okay, it's completely fine, right? Cell swelling will happen. You'll have bleb formation. You'll have swelling of endoplasmic reticulum, detachment of ribosomes. All these are your signs of reversible cell injury. After that, what will happen is increased permeability to enzymes. That's like a point of no return. Once enzymes come inside, along with that calcium also will come inside. Calcium actually comes inside. That activates enzyme phospholipase, protease, and nuclease. This ruptures the cell membrane. This will destroy the protein. So automatically becomes darker pink in color. Destroyed protein is always darker pink. Nuclease, obviously what it'll do? It'll do your pycnosis, it'll do your karyorrhexis, it'll do your karyolysis. So finally in the microscopy of necrosis, I'm going to see only pink color. And all these guys will be finally removed by macrophages or your inflammatory cells, right? This is in short about the pathogens of necrosis, right? Perfect. Caseous, coagulative, liquefactive, fat, fibrinoid, right? That's all. So coagulative is the most common type. Two things. What is the mechanism of action? And one microscopic feature here. Will there be preserved cell membrane, cell architecture, or a destroyed cell architecture in coagulative? Mechanism of action is protein degradation. That is the primary mechanism of action here, protein related degradation. And here you'll have a preserved outline. Okay, preserved cell outline, and that's what we call it a ghost cell. Fine. You'll have a ghost-like morphology. It'll have a preserved cell outline. That's classical for coagulative. Every solid organ, in fact, except one guy. What's that guy? Obviously brain infarct. I didn't write that, but yes, obviously brain infarct, abscess cavity, wet gangrene, wherever there's more neutrophil, or in other words, the mechanism of action here is enzyme activation, or even acute pancreatitis. Enzyme activation will cause liquefactive necrosis. Microscopy, there is no ghost cells. I won't have preserved cell membrane architecture because everything liquefies, becomes a liquid, and it will be gone. Perfect. Okay. Third guy is caseous necrosis. Caseous was actually a subtype of coagulative necrosis. What I'll see is microscopy is a granular variant of necrosis. That's what you will see in microscopy. Boss is TB, right? But any other examples for caseous necrosis? Yeah, your histoplasmosis, coccidiomycosis, even bit of a neuritic leprosy can also have caseous necrosis, right? Microscopy will be a granular variant of an coagulative necrosis. And gross, that's a unique part here, right? It's cheese-like. It's a cheese-like whitish to yellowish color of necrosis. What is caseous necrosis? Fine, perfect. Fibrinoid. Oid means like. Fibrinoid necrosis, microscopy, obviously it will be one important finding. It will be Pah positive. Anything in the vessel, which could be vasculitis. Just now we saw an hypersensitive reaction. Type 3 hypersensitive reaction, any vasculitis, right? Malignant hypertension. And there's one condition where you'll have ash of bodies. Can anyone tell me that condition? Because malignant hypertension, the blood vessel wall will rupture, right? And also we can see them in rheumatic heart disease. Not in rheumatoid arthritis, rheumatic heart disease. In your Ashoff body, you can see this guy, fine? So all these are classical examples for fibrinoid necrosis, right? Perfect. Atherosclerosis to some extent, but atherosclerosis is more of a chronic inflammation. It will alter, might see fibrinoid necrosis at the early half, fine? Okay. Last but not the least, guys, fat necrosis. Two types of fat necrosis. One is trauma-induced, traumatic fat necrosis, any organ rich in fat. That's all. And the other guys, enzymatic fat necrosis. Enzymatic fat necrosis, what happens? In case of an acute pancreatitis, the lipase is going to leak outside and the lipase destroys omentum. Please use it example omentum alone. Don't use the example peripancreatic fat. Not very easy. Don't make the examiner search for an answer. Always want omentum. Omentum should be first. Then if you want to add peripancreatic fat, right? If you want to add saponification also. But you know for a fact that calcification happens in every necrosis, not just fat necrosis. It will happen in every necrosis, right? This is in short about necrosis. Fine? Got it. Now, can you recap the similar way about apoptosis? Possible? Yes. Ready? No, Vinay. Fat embolism is caused because of a long bone fracture like a femur, where the bone marrow has fat, right? That will fracture will break a vessel, and the fat from the bone marrow enters the vessel. Fat embolism and fat necrosis are totally different. Fine. Okay. Got it. Perfect. Now let's do apoptosis. Physiological, pathological, both. It's absolutely both physiological and pathological, right? That's a programmed cell death. There are two phases in apoptosis, right? Physiological, we'll have examples, all the embryological example, loss of the thyroglossal tract, all the webbed fingers, everything are example. Pathological, DNA damage, viruses, two main examples for pathological apoptosis, mutation and viruses, right? So there are two phases of apoptosis. One is intrinsic. What's the other name of intrinsic? And the other is extrinsic. Intrinsic, or the other name is what mediated? Mitochondrial mediated. Extrinsic or cell membrane mediated, right? That's the intrinsic and extrinsic, fine? Perfect. So in the intrinsic phase or the mitochondrial phase, where we have all the proteins, right? The bags, bag, BIM, BID, BAD and everything, right? So which of these do you think is pro-apoptotic? Which is pro-apoptotic? Anti-apoptotic is what we'll know. Anti-apoptotic is no cell death, longer life. Whichever is L is anti-apoptotic, right? BCL2, BCLXL, MCL. Pro-apoptotic is two guys, backs and back. That's all. And there are few guys called as sensors of cell stress. BIM, BID, BAC, Puma Noxa. BIM, BID, BAC, Puma Noxa will understand the stress, stop BCL2, activate backs and back. Once backs and backs activated, who will come outside? Which guy? One guy from mitochondria will come outside, cytochrome C. Cytochrome C binds with an activating factor called as an APAF, forms an apoptosome, and apoptosome finally activates the final enzyme caspase. In an intrinsic, it's caspase 9. Extrinsic has same mechanism. The only difference is what ligand will mediate extrinsic. We call them death receptor, CD95 or FAS. FAS and FAS ligand will bind, activates the FADD, fast associated death domain, that will activate cytochrome 8 or 10, right? After that, the cytochrome 8 or 10 or cytochrome 9 will converge to the execution phase, which will activate two guys. One is further caspases 3 and 6. What's the nuclease? Normal nuclease or an endonuclease? 11. Endonuclease activation. Once endonuclease activated, it cannot destroy the DNA, but it can fragment the DNA. Since there is no phospholipase, will the cell membrane be damaged or not? Not damaged. If the cell membrane is not damaged, will intracellular contents leak outside? No. Will there be inflammation? Generally, no. This final step is called as an apoptotic body, which will also be removed by macrophage. What's a special type of phagocytosis called here? We call it efferocytosis, right? Perfect. That's a simple call of apoptosis, right? See, I'm not repeating apoptosis with respect to a physiological, pathological, examples of physiological, pathological, right? We'll just focus on the intrinsic part of apoptosis, the extrinsic pathway of apoptosis or the cell membrane mediated. Intrinsic pathway, whenever there's a DNA damage, it will activate the sensors of cell stress. These are your BIM, BID, BAD, and Puma and Noxa guys. So BIM, BID, BAD will reduce or destroy BCL2 and will increase backs and back. Backs and back are your ion channels on the inner mitochondrial membrane. This will increase the exit of cytochrome C. Cytochrome C will bind with one more protein called as APAF1, apoptosis activating factor 1, that forms a complex called as an apoptosome. So means always a combination of proteins, right? So it produces apoptosome. Via the apoptosome, whatever caspase goes inside from a procaspase 9 becomes an active caspase 9. 9 is the number for intrinsic phase of apoptosis, right? Extrinsic phase, same way. We had virus. Whenever a virus is there in a cell, the FAS receptor or the CD95 or the death receptor, however you want to call it, binds to ligand, FAS ligand. Once this binds, it will activate the downstream complex called as an FADD, fast associated dead domain. That will activate again procaspase 8 or 10 to active caspase 8 or 10. So these two guys further will trigger your execution phase. So once I trigger an execution phase, I have two things in execution phase. Again, caspases. Talk about caspase a little bit more here. Caspase are nothing but cysteine aspartic acid proteases. They are primarily proteases, right? 3 and 6. And I'll activate one more guy, endonuclease. So once endonuclease is activated, it will cause this very, very important. Write this. I will look for this in exam. Chromatin condensation or chromatin breakage. It will not cause lysis, only condensation. That's the hallmark of apoptosis, right? Chromatin condensation. Obviously, this will cause protein destruction. Okay. So now I want you to relate the final process into microscopy. See, always in necrosis also, na, final process will be related to microscopy. What I'll be seeing at the end of it, right? Apoptosis also, final process has to relate to microscopy, fine? A normal cell with a superb nucleus, and if you possible, use the pink and blue and properly represent them. At the end of this, it becomes smaller or bigger? The nucleus also will be condensed and will be small. And the pink color also will be condensed and small, right? So this will be a smaller cell, darker cytoplasm or pink, dark pink cytoplasm. Fine. Perfect, Dipshita. And 11, pycnotic or a very condensed nuclei. Okay. So it's condensed nuclei, and all these what we're going to term them as apoptotic body. If you want, write an example of Councilman body. Councilman body is apoptotic body in hepatocyte. You see in hepatitis. Wherever you see apoptotic body, it will look the same. Smaller condensed cytoplasm, dark cytoplasm, and a dark nuclei, right? And these will be finally removed by phagocytosis without an evidence or without an inflammation. We call it efferocytosis. It's a specialized phagocytosis which is very quick. When we are hungry like that, eats without any clue, right? That's what efferocytosis is, right? Once it's done, if it's a long answer or even a short answer, I want you to end with methods to identify apoptosis. At least the name. Fine. Names must. One is normal H&E, right? Second, talk about DNA agarose electrophoresis. What will be the pattern in apoptosis? Because of the broken DNA, we'll have stepladder pattern of apoptosis. Do write them. Fine. 3, a molecular based assay called as a tunnel. Tunnel is nothing but an IHC, a modification of an IHC called as a tunnel, right? Because I won't have cell membrane damage, I cannot use enzymes to identify. I'll have to use this to identify. Perfect. If you remember annexin, write annexin as well. Fine. Annexin also, right? So these are methods to identify, that to end. Introduction, you know. Physiological, pathological examples, you know. You will definitely not forget program cell death. Then we have the entire process, fine. I might not ask a question of in case of a cell adaptation if I'm an examiner, because you guys know about hyperplasia, hypertrophy. Maximum I might ask metaplasia. You will definitely write about Barrett's and everything. In the intracellular accumulation, if I'm an examiner, I'll definitely ask about calcification. Write a short note on pathological calcification, which can be dystrophic or metastatic, right? Tell me examples. Let's start. In which of these two do you think it will happen in normal tissue? Few important information is required, that alone will concentrate. First, with respect to tissue, dystrophic will be normal or abnormal? It will be completely normal tissue. Dystrophic is, dys means abnormal, right? It will happen abnormal, or in other words, degenerating tissue or a dead tissue, right? That's where it will happen. Metastatic, change in the homeostasis. So the serum calcium level, where it will be elevated, metastatic or dystrophic? By default metastatic. Dystrophic it will be normal, right? That's it. Because of the elevated serum calcium is where even a normal tissue is getting deposited. Mostly will deposit in capillary rich structure. That's what we read, right? So examples here of hypercalcemia or causes. So causes here is ultimately which causes hypercalcemia. Whichever it causes hypercalcemia can cause metastatic calcification, right? Can be an hyperparathyroidism, right? Obviously. Can be a problem in vitamin D toxicity. Obviously. Can be a problem where bone is being resorbed. Any bone resorption. Fine. It could be an as simple as myeloma. Myeloma causes punched out lytic lesion, right? And you should know that myeloma will cause hypercalcemia. Any cause of hypercalcemia which comes to your mind, right? Milk alkali syndrome if required. Paraneoplastic syndrome, perfect, right? So anything which causes hypercalcemia can be written. Like I said, the beauty, at the end of pathology, paraneoplastic syndrome will not be mentioned in metastatic calcification, but Ipshita can answer it. You guys can answer it because you know that, right? Sure, Ashim, I'll do it. Okay. So organs where it will be deposited is renal, lungs, the most common, kidney, it can be in GIT, and also it will alter the brain's function because of hypercalcemia. If you remember, we had a mnemonic, right? Abdomen pain, kidney stones, psychic moans, and abdomen groans, right? Because of all this calcium deposition, right? And here the cause is degenerating in dead tissue. That's all, right? So it could be just an very old aortic valve of an elderly person can have it, and it could have a necrotic tissue. The classical example of necrotic tissues, samoma bodies. Samoma means sand like deposit of calcium. You know where to write samoma bodies, right? Which all tumors will have samoma bodies? If I made sense in the 1 year what you have been with me, you know the answer. Anything which is a papillary appearance, anything which is in the world architecture will have samoma body. Papillary tumors, serous tumors, meningioma, leiomyoma will have samoma body. That's all we know about it, right? Finally, to end with, microscopy, the color of calcium is always blue in color. Blue color, what do you have to do? I cannot identify or differentiate between nucleus in this. So obviously we need a special stain. Special stain 2, guys. It's calcium, right? COSA and alizarin. Alizarin is a better guy than 1 COSA. Fine. Perfect. 1 COSA or alizarin, these are two stains for calcium. That's in short note about calcification. Fine. Okay. Inflammosome pathway. Fine. Just give me a second, Rishank. See, inflammosome pathway is what we read in pyroptosis, right? So what happens here is, let's say I'll take in general about inflammosome pathway, you can modify it to whichever disease you want, right? Any intracellular pathogen. When I talk pathogen, it could be a bacteria like a mycobacterium, right? It could be an lipid like an atherosclerosis. It could be a uric acid, right? It could be lipid. It could be uric acid. Anything intracellular pathogen will bind to a receptor called as nod-like receptors. Nod-like receptors are also called as an NLR, right? So binding to nod-like receptor, this is the guy which activates or increases the inflammasome, forms the inflammasome complex. So once inflammasome pathways complex is being formed, inflammasome is nothing but an interleukin 1 beta converting enzyme. Converts interleukin beta from an inactive form to an active form, right? This, let's say IL-1 inactive form, this converts them to IL-1 active form. And this guy is no inflammasome. Also does few things. That's what we read in pyroptosis. Activates caspases, the procaspase 1, 4 and 5 to active caspase 1, 4 and 5. Fine. So this interleukin 1 will trigger more inflammation, and caspase obviously will cause cell death. So this is what primarily happens in pyroptosis. The same thing you can write for atherosclerosis, same thing you can write for gouty arthritis, same thing you can write for any intracellular pathogen which activates not like receptors. Fine. Okay, Rishank? Perfect. Done. Okay, let's quickly go to inflammation. Right. So inflammation, we have two guys, acute and chronic. Will you forget ever the hallmark of chronic inflammation? What's the hallmark of chronic inflammation? The first chapter I told you, right? Half of pathology is due to only one guy, this guy, TDHF. I hope you agree now, right? It's tissue destruction, healing by fibrosis. Cannot change, right? So acute inflammation happens in hours, 2 days to start with. It can not even days, generally only hours. This can be days, this can be months, this can be years. Acute inflammation cell, two guys, neutrophil, predominantly neutrophil, right? Eosinophil also, if it's due to allergy. Fine. Sure, Rishan. Give me a little bit of a moment. We'll complete this and talk about necroptosis, right? Cell of chronic inflammation by default is macrophages. If it's an autoimmune disorder or a viral etiology, then I'll talk about lymphocytes. Hallmark of acute inflammation is vasodilatation and increase in vascular permeability. Remember, as a mosquito bite, lump, increase vascular permeability. That's all. Fine. Okay. Here, hallmark of chronic inflammation, tissue destruction, healing by fibrosis. Right? It's TDHF by default. Fine. Ruber-Callard, that is my cardinal signs of acute inflammation. Yes, that also you can write, Ipsita, that's true. But hallmark will stick with what happens in the inside the body, vasodilatation, increase in vascular permeability. Fine. Okay. Quickly, let's recap the events of inflammation. Events of inflammation, I don't think it has been asked much about it, but yes, you need to know about selectin ruling. 2 mark questions, it might come, right? First is, we divide inflammation to two pathways. Vascular phase, cellular phase, right? Vascular phase is any change in the blood vessel. Initially, there will be a vasoconstriction, then vasodilatation. Vasodilatation is what causes this. This is due to vasodilatation. It's vasodilatation mediated, and a molecule called as selectin here helps. That's all. So what happens is the normal vessel becomes dilated, so everything causes turbulence. Because of the turbulence, the laminar flow, the cell goes to the corner. That's margination, right? All the cell goes to the corner. From cell in the corner, there'll be an endothelial gap. It has to go to the endothelial gap. That's where rolling adhesion diabetes happens, right? Just give me a second. I'll show you a video, then we'll quickly go into it, right? Just a second, just a second. I've removed the thing. Just a second. I hope I have the video. Okay. Okay. So it's a guy. So cells flow like this in a laminar flow because of the vasodilation. Margination comes to the corner, and you'll have cytokines already from the inflammatory side. These cytokines are the one, interleukin 1 tumor necrosis factor are the one which elevates the selectin. Selectin is there here. Sialalux X receptor. Selectin is here, and on the membrane we have the carbohydrate receptor binds. This binding is a weak bond, so it rolls. The blood supply pushes them, and it goes to the site of the gap formation where it stops. The stopping is because of two more guys, integrin and the CAMs, cell adhesion molecule. Cell adhesion molecule is here, integrin is here, and then it goes outside. Two guys, when it goes outside, yellow guy will be destroyed by collagenase and diapedesis. From there, it moves like an amoeba slowly to the site of infection. That's your chemotaxis. After that, your respiratory burst and everything comes there, right? Those are the steps of inflammation, right? Just a simple way. If you have this video, it's from YouTube only. Take it, see it in the last moment. That should be more than enough, right? Rolling adhesion diabetes, all of them, you'll have just few molecular factors. That's all, right? Thank you, Niket. So in endothelium and WBC, endothelium we have selectin. If it's a long answer, write about E selectin, write about P selectin, L selectin, not that much involved, right? P selectin we have in your Weibel palate bodies, along with who? Along with your von Willebrand factor, right? WBC, you have Cialyl-Lewis X receptor. And you can write this bond has a weak bond, so it will roll. Second guy is addition. Same, endothelium, maybe we have CAMs, cell addition molecules. On the surface of a WBC, we have integrins. We have integrins and we have CAMs. And this binding is a very, very, very strong bond. F is a long answer. If you want to expand, write ICAM and VCAM. Vascular sedation molecule, intercellular sedation molecule, integrin also, if you want, write beta 1 and beta 2. Beta 2 are the more important ones. Need not go beyond that for a long answer. Beta 1, beta 2 integrin is more than enough, right? And like I said, strong bond, so it will stop the movement. Diapetesis again is a two-step process. CD31 or PCAM1 helps to squeeze and go outside, right? It helps in the squeezing and the exit of the cells. And the non-specific collagenase, which is there in the primary granules of the neutrophils. This will help in the causing the pores in the endothelium's basement membrane so it can go outside. Then we have chemotaxis. First, it's a unidirectional movement. Chemotaxis undoubtedly is due to actin polymerization. Because of the actin polymerization is where it moved like an amoeba. It has to move like amoeba. Actin polymerization means G-actin to F-actin. That's what it is. Same what you read in your physiology, right? So we have two guys. Endogenous. Can anyone tell me one endogenous chemoattractant factor? Very important one. Exogenous, you can write a lot. You know, complete bacteriology now, right? Lipopolysaccharide, flagella protein, pyelin, lots of them are there. Endogenous, leukotriene B4. You guys forgot that guy. Complement factor A. Chemokines, right? Chemokines is a better term, right? Chemokines rather than writing all the types of chemokines. Leukotriene B4, complement factor 5A, and any chemokines or even your interleukin 8. Don't forget leukotriene B4 and complement factor 5. These two are very, very important chemoattractant protein, right? Because of that, they came to the end and phagocytosed. What I didn't have here is, we'll add that also, right? Why to worry? How to kill? After phagocytosis, we kill the organism by two ways. One is non-oxygen dependent pathway, which is a very, very weak mechanism. The other is oxygen dependent pathway, which is a very strong mechanism. We call it respiratory burst because it uses what? Oxygen. Very simple flowchart. Oxygen, tell me the enzyme. I'll write only the output here. From this output, it goes to your H2O2. I want you guys to fill every enzyme here, right? From H2O2, I have two output here. One based on neutrophil, one based on eosinophil. Based on neutrophil, with the help of chlorine, here also I want you to tell the enzyme, produces HOCl, a perfect bactericidal. With the help of iodine, produces hypoiodide, a perfect free radical to kill the parasites. Perfect, Vinay. The first guy is NADPH oxidase. The second guy is superoxide dismutase. Right, recent FMG exam had a question, superoxide dismutase mutation. Na? If it's in 1 mark question, SOD1, SOD mutation can result in a disease called amyotrophic lateral sclerosis. Fine, it's a neurological disorder. You'll read when you come to medicine, right? Perfect. This guy, which has chlorine, is MPO. This guy is major basic protein, similar M, right? And because this involves chlorine and everything, we call it halogenation as well. So now I have successfully destroyed this guy. If you have successfully destroyed this guy, what's the next thing? Termination of inflammation, right? After success, obviously you have to stop reading after your second year success, right? No, we'll continue, but inflammation should stop, right? So you'll increase your interleukin 10, increase your TGF beta, increase your lipoxins, resolvins, everything. This will stop inflammation, right? That's in short about inflammation. Automatic inflammation will stop. And who produced all this? Your M2 activated macrophages. Right? The M2 activated macrophages created all this and destroyed all of them. Fine? And stopped the inflammation. Perfect? Done. That's in short about a simple screenshot of what happens in inflammation. Okay? Now let's go to your disorders of inflammation. Tell me what is happening. What is defect? That's enough. I'm sure you know a little bit more than that. Just tell me what's the defect, what is happening here. One clue, all of them are autosomal recessive disorder. Add only one thing. This guy alone has X-linked disorder as well as autosomal recessive inheritance, because the enzyme which is mutated here has two parts, membrane and cytoplasmic. Fine. So here you'll have a beta 2 I. One looks like an I, integrin defect, or just write integrin defect. Here, don't write selectin, it is Cialal Lewis X defect. Right? Perfect. This is your NADPH oxidase defect. Chidiac-Hayashi syndrome. What's a gene defect? MPO deficiency. Obviously, MPO defect, right? Chidiac-Hayashi, yeah, LYST gene or lysosomal transporter. Because of that, I have reduced phagolysosome formation. Fine. If you know this, problem है ना, Aniket, I'm recording Hindi lectures, so thoda Hindi I'm trying. I hope that it'll come out good. Fine. Perfect. Firm T3 is for LAD3. If you know that, you can add that to as well as Vinay. Fine. Great. So these are your classical mutations. If you know this, that's more than enough. Extra 1 point if you write, yes, that's more than enough for you to get a distinction also. One common finding for every disease, no? More infection, recurrent infection, reduced immunity. That's one common finding for anything, right? So here, I'm not going to write that part. A very unique finding for LAD1 is delayed separation of umbilical cord. Right? That's a classical finding. A very unique finding for LAD2 is Bombay group. A very unique finding for your NADPH oxidase defect is only catalase positive organism infection. Fine. Only catalase positive organism infection, and also remember this test, NBT test. NBT test helps in diagnosis, right? And a very unique finding for Chidiac-Hayashi syndrome. Specific finding for diagnosis is giant granules on microscopy in WBC, and other finding unrelated to immunology is albinism, because LYST helps in the transport of melanocytes, and peripheral neuropathy, because LYST helps in the transport of Schwann cells. Fine. Purpura, because of thrombocythemia. Unrelated to immunological defect. MPO is like wastebasket. Autosomal recessive, very, very mild disease, as both catalase positive and catalase negative organism infection. Fine. This is a very short form for all the immune deficiency disorders, which can come in a, I don't think it should come in a 5 mark or anything, 2 mark or an MCQ maximum, right? They should not ask in a 5 mark, but they ask, be prepared. Okay, that's about it. That's about acute inflammation and a quick recap of all the inflammatory disorders. Fine. Let's go to chronic inflammation. Chronic inflammation, we'll discuss about the pathogens a bit in detail. Same pathogens for type 4 hypersensitivity, same pathogens for anything you have granuloma formation, right? So our goal here is to understand TB. TB enters the body, TB will be eaten by the macrophages, right? I cannot destroy the TB, unfortunately. So macrophage will present as an antigen presenting cell. With the help of your MHC2 complex, it will present to my CD4 cell the TB antigen. Once it binds to the TB antigen, what the CD4 cell does is, it will convert to TH1. TH1 releases interferon gamma, right? Interferon gamma is a very, very important molecule to remember, because interferon gamma, there's a test based on that called as a quantiferon gold test. Because of the interferon gamma, your normal macrophage becomes an activated macrophage. Everyone, what's the function of activated macrophage? Activated macrophage function, that is secretion, not phagocytosis. It's secretion, and this activated macrophage, one more name is epithelioid macrophages, because they secrete protein, so the cytoplasm becomes pink. They secrete, so all the nucleus goes to the corner, looks like a columnar epithelium, so we call it epithelioid macrophages, right? They secrete, what do they secrete? They secrete interleukin 1, they secrete interleukin 12. Interleukin 1 and 2 brings more T cells. Interleukin 12 converts T cells to T helper cells, vicious cycle. Secretes interferon gamma, more of them. And these guys also secrete nitric oxide and reactooxygen species, which helps to kill the bacteria. Obviously, I have to kill the bacteria, right? That's ultimate goal. And these guys will definitely unite to form giant cells. So the principal cell of granuloma formation is undoubtedly your epithelioid macrophages or your M1 activated macrophages, right? This is short about granuloma formation. And what you see here is in the center, we have all these epithelioid cells and giant cell. What do you see in the corner? All these are small round blue cells, right? What's that? Lymphocytes. So that's how a granuloma looks like. Perfect. Any pathogenesis across the body where have granuloma, same. Even including silicosis, asbestosis, same. Crohn's disease, same. It will not change. It will be the same, right? So we divide granuloma into necrotizing and non-necrotizing. There's one basic difference. What's the difference? The difference is simple. What's that? That's there is a killing happening. I can kill. And here I can't kill. That's all. By default, both is TB. Never forget. It has to be TB by default. My body can kill TB if my immunity is great. My body cannot kill TB when the immunity is not great. That's the first thing for both necrotizing and non-necrotizing. But here we already know we have histoplasma, we have coccidiomycosis, we have pure neuritic type of leprosy. Right? All these are other causes of necrotizing granuloma. Non-necrotizing, non-cashiering, you know a list. Can anyone tell me one example for non-necrotizing granuloma apart from sarcoidosis? I don't want sarcoidosis. Occupational lung disease, everything will have. Crohn's will have. Ulcerative colitis, not much. Hodgkin's will have. Foreign body will have. And by default, the last one, what's that? Your sarcoid also will have. Right? Cat scratch disease, that will go into special type of granuloma. Cat scratch might have necrosis, fine. It will have a stellate granuloma, cat scratch, donut shaped granuloma for Q fever. Those are special type of granulomas, fine. Okay. So we have your stellate granuloma in cat scratch. We have donut shaped granuloma in Q fever as well as in allopurinol toxicity. Because it looks like a donut, in the center there'll be a fat molecule. It happens in liver and bone marrow, right? And you have microgranuloma, where they are very tiny granuloma, no giant cells in case of a toxoplasma. Fine. There's something called drugs granuloma, which happens in the brain in case of falciparum malaria. Almost non-existent cases, so we'll ignore that, right? So this is in short about different types of granuloma. If a question on granuloma is asked, write a note on Langerhans type of giant cell, two-tone type of giant cell, foreign body giant cell. Do write them, right? But this is in short. One page can cover all the things required for granuloma formation, fine? That's with chronic inflammation. Done. We know acute, we know chronic. One question in genetics, right? I feel that, see, genetics for you in your CBM curriculum is very, very limited. Maximum I can ask syndromes, these, because there's no way I can ask how to write about the risk factor for relative risk calculation for dominant and recessive. Features of dominant recessive, I cannot. I can ask in one liner. But in a 5 mark, it should be either genetic diagnosis like karyotyping, all those things, or Turner's, Klinefelters, Downs, Marfan's. These are the questions which I can ask from genetics. I can ask MCQs, but very unlikely to ask a 5 mark question, right? Turner's only live monosomy. Rest every other monosomy dies. 45 exos Turner's. Pathogenesis, meiotic non-disjunction. Don't expand. It's self-explanatory. During meiosis, it's not separating properly, so it'll have a monosomy and a trisomy. The monosomy will be Turner's. Anaphase lag, where the chromosome lags during anaphase. Chromosome lags behind during anaphase, a step of your mitosis and meiosis, right? And you have structural abnormality, which means sometimes the X chromosome becomes, the edges will be cut. Because of that, it becomes sticky and becomes a circular ring. And this ring is not functional. It's not functional. So there's a structural abnormality. It cannot function because it cannot involve in transcription and translation formation, right? Shreyasi, very unlikely, but if you want, we'll discuss about that soon, right? So here how will I write is 46XX ring chromosome of X. Remember, if you're writing ring chromosome, it should be 46, not 45. Structural abnormality will always be 46 chromosomes, not 45 chromosomes, because number wise they are there, function wise they are not there. Isochromosome means, let's say this is my chromosome and it will be separated along the vertical axis. If it's separated along the vertical axis, I'll have, separate along the horizontal axis. Normally it will be separated along the vertical axis. If it's separated along the horizontal axis, what will happen? You'll have two Q arms in one and two P arms in one, right? And this 2Q arm is a problem. So we'll write 46X isochromosome XQ, because XP is where I have all the important genes. So when I have 2XQ, no XP, it acts like a Turner syndrome, right? So these are different pathogens of Turner syndrome, right? Symptom: Turner's kids are short. Remember, circus clowns. They look like clowns. Should not say that, but that's a mnemonic. C for congenital heart defect. You might definitely know about the terms now, right? Coarctation of aorta. The aorta becomes narrowed. That's one. Low thyroid, low hairline, right? O for ovaries being atrophied. What's a special term given for this? That can come in an MCQ. Streak-like ovaries. Streak-like, because of this, the patient may present with primary amenorrhea. The kids might not menstruate because of not functioning. There's no ovarian function at all, so you'll have primary amenorrhea. Web neck. What's a technical term for web neck? I'll have a lymphadenopathy here. We call it cystic hygroma, right? And nipples are widely spaced. We name this cystic hygroma. And nipples are widely spaced. The reason for this, the patient will have a shield-like chest. The problem is not because of the nipples. The chest wall becomes like a shield. So obviously nipples becomes widely spaced. And the most common feature is short stature. There's a very, very specific feature. That is short fourth metacarpal, right? That's a very specific feature of Turner's which can be seen on an X-ray, right? So clowns is a very good mnemonic for you to remember for Turner syndrome. Diagnosis simple. Clinically, to confirm to a karyotyping or a fish, that should be more than enough for you to diagnose Turner's. Fine. Okay, that's one thing which you want to talk. Should we talk about Angelman-Prader-Willi as well? Let's do it. We have time. Very unlikely to ask Angelman-Prader-Willi in short note. If they ask, let's talk about imprinting, and also we'll talk about the Angelman and Prader-Willi. Fine. Hi, bad doctor. Become a good doctor. Right? You are a good doctor. Change the name or put your name. That's more important than the bad doctor. Fine. Okay. So let's go to imprinting. What is the process of imprinting called as? Imprinting is silencing of the gene. It's a normal phenomenon. It's not an abnormal phenomenon. Right? I will have disorders of imprinting. There are two disorders of imprinting, which is Angelman syndrome and Prader-Willi syndrome. Fine. We had a mnemonic, right? Created by one of the students, Dr. Nishant, right? So how many guys remember the story of Dr. Nishant's angel baby? If you don't, let's recap. Nishant said that there is a kid called Angel who is 15 years old. Kid's mom and dad had a divorce, so the dad was out of the equation. Angel and the mother was very, very happy, but one unfortunate day, mom died. Angel was alone. Angel went in search of a man, found a man, married, became a syndrome. She was very, very happy, so had called as happy puppets, but internally she was laughing without any reason. That's a classical symptom of Angelman syndrome, right? And we can easily correlate that. Chromosome 15 is a place. Angel is present everywhere. So the gene is ubiquitin 3A. It's a ubiquitous gene. In the story, father was already out, which means normally the dad's part of the genome will be imprinted or silenced. So pathogenesis, two parts. Actually three. If you write two, that's more than enough for me. The most common thing is, so who's the only functioning allele here? Moms. So maternal deletion. Maternal deletion of the ubiquitin 3A gene will result in a problem. Second is disomy. Di is 2, chromosome somy. We call it uniparental disomy, right? That's my second pathogenesis. If I have a paternal disomy, which means expand if it's in a short note, I'm just writing short away. Paternal disomy. Both the chromosome 15 comes from the father, which means both the chromosome 15 will be imprinted. No functioning chromosome 15, which happens like that, right? Last but not least is a problem in imprinting. By a defect, everything gets silenced. That's very, very, very rare, but a problem in imprinting can also happen, this, right? This is Angelman. Prader-Willi is exactly opposite. Symptom also is different, right? Same chromosome 15. The gene is SNORP gene, where you have all the spliceosome small nuclear RNA production, right? It's a group of genes, SNORP group of genes. And like I said, it's exactly opposite. So imprinting is mom's gene is imprinted or mom's allele is imprinted. So pathogenesis is a reverse. What's the most common cause? That's deletion or paternal deletion. Whose disomy? Mom's disomy, maternal disomy. By default, you can add defective imprinting here also. Defective imprinting is like 1-2%. Need not worry about that. If you write the first two of them, that will take care of almost every case of Angelman and Prader-Willi, right? Symptoms. We cannot stop without symptoms, right? Can anyone tell me the symptom of Prader-Willi? This I told the exact symptom. We call them happy puppets. Reason? They laugh without a reason, right? Inappropriate laughter. Joker. That's what we read during the class, right? Joker in the DC universe. Inappropriate laughter. Perfect, Ipsta. Why overeating? Why is always the reason, right? So there'll be here increased ghrelin secretion. Because of more ghrelin, there'll be more appetite. Because of more appetite, overeating, and the kids will have childhood obesity. Fine. Shreyashi, if you're still there, a short note on Angelman as well as Prader-Willi. Fine. Clear? Okay. That's few things which can come in genetics, right? Shock. Let's talk about shock, maybe a bit in detail, right? Shock is something, there's a very likely possibility it can come in an essay, right? I think most likely it can come in an essay. Most likely septic shock, right? So what are the types of shock you know? What are the types of shock you know? We have cardiogenic shock, we have neurogenic shock, we have septic shock, right? Cardiogenic, neurogenic, very easy to remember and very easy to write, or hypovolemic shock also, right? All of them pathogenesis is same. I lose the blood, heart is not functioning, neurologically vascular tone is gone. When I lose blood in hypovolemic shock, you have the same mechanisms of vasoconstriction, RAS activation. Finally, it will go to an irreversible phase where it dies. That's what, fine? Hypovolemic, cardiogenic, anaphylactic, fine? Bad doctor, you are giving exam when? I'll let you know if this notes will be there in Telegram group. If you're asking about the PDF, we'll definitely let you know. I'm not exactly sure. Might not be updated this time, but definitely soon. We have already added the Farre second edition where we had you have this 5-mark question on this 8 nodules, no? That's already been added and updated. Just have a look at it, fine? Okay, let's come back to this. So where hypovolemic shock, reversible, irreversible, and irreversible stage, finally it will go to death. That's the hypovolemic shocks timeline, right? Septic shock is a bit unique, and septic shock is something which I want you to remember as well. And how do I know it's septic shock versus hypovolemic shock clinically, right? Because most of the time it'll come in LAQ. Hypovolemic shock, you'll have either a road traffic accident, uncontrolled vomiting or diarrhea as a symptom or as the cause. Septic shock, you'll predominantly have an infection, high-grade fever that will be there, right? But there's one very unique thing, but in most of the exams, they are being written wrongly, which will have cold, clammy skin. Most of the shock will have cold, clammy skin, but that's very, very unique for one of the shocks. What is that? Which type of shock do you think will have a very cold and a clammy skin? Hypovolemic or septic? Cold, clammy skin. It'll be in hypovolemic shock, right? Which will have vasodilatation in the extremity. Hypovolemic, septic. Vasodilatation, by default will be there in a septic shock, right? Generally, septic shock will have vasodilatation, which results in a warm periphery. Hypovolemic shock will have vasoconstriction because I have to divert the blood to the brain and the heart, so I'll have a cold periphery. This should be the most important difference in a scenario question. But if they write cold skin and a history of infection, still I will go for sepsis. Fine. Yes, still I'll go for sepsis. Most of them, it might have a problem like when I said, fine. Hi, Prem, all the very best. Come back soon next year. We'll read about medicine more in detail, right? Okay. Septic shock. Shock is a state of circulatory failure which impairs tissue perfusion and leads to cellular hypoxia. Definition. If you want to write septic shock, add on to that. The reason for that is infection and propagation of infection and endothelial damage, right? Etiology of septic shock. Gram positive, gram negative. Fungal sepsis is bit very unlikely. You know that bacterial sepsis are definitely much more common than fungal or viral organism, right? You can write any organism. Klebsiella, Pseudomonas, these are must. I'll tell you why. Because one of the important guy is E. coli, urinary tract infection, right? Or in catheter-based blood skin infection, E. coli, right? And Staphylococcus streptococcus is also important. Pneumonia can be there. A localized infection can spread and gain entry into the blood circulation that results in shock or sepsis. Pneumonia will definitely progress to sepsis, fine? So these are my infectious organism, little bit, and also about the common source of the infectious organism, fine? Maybe half a mark to 1 mark. Etiology, 1 or 2 marks. The most important thing is pathogenesis. Outcome will definitely come into it, right? Pathogenesis is something which is more important, right? Can anyone tell me, do you know any important keywords or headings you look for pathogenesis? There's a very amazing flow chart in Robbins. That's a compilation. But you want headings for pathogenesis. Any important headings you know? The first thing is inflammatory and counter-inflammatory response, which means my organism will elicit an inflammatory response, very high inflammatory response, counter-inflammatory. Because whenever something goes up, I'll obviously suppress it. When it's suppress it, bacteria divides. So there's a balance, right? Automatically happen. Whenever there's an inflammatory response, endothelium will get activated and endothelium will get injured. Once endothelium is injured, obviously it will trigger DIC, procoagulant state. Once I have the procoagulant state, that is like a vicious cycle, it automatically ends. In addition to this, I'll have metabolic abnormality also. Fine, perfect. 4 headings I would want. One is inflammatory and an counter-inflammatory response. This is must to be there. The reason is very simple. Whenever there's an excess of bacteria in the blood, this will definitely trigger inflammation. You can write all the inflammatory mediators which comes to your mind, but important is my interleukin 1, TNF alpha. So whenever this inflammatory response is in the peak, my body will automatically activate anti-inflammatory response because I have to protect the body from peaks of inflammation. Or the counter-inflammatory response could be in the form of a steroid produced by my body, right? So the counter-inflammatory response is what is going to cause your reduced immunity. The reduced immunity unfortunately is counterproductive, which can increase the bacterial load. If it's a bacterial organism, that can actually cause the inflammation. So it's a vicious cycle. That's the inflammatory counter-inflammatory response, the first part. The second part, like Ipsa said, there's an endothelial activation and an endothelial injury, right? That's my second part. We'll have endothelium related. The first is activation. Because in acute inflammation, so obviously there'll be an increased vascular permeability and vasodilatation. Because of this is why you have a very warm extremity or a flushed skin because of vasodilation and increased vascular permeability, right? So this endothelial activation will go and end up in endothelial injury and damage, right? Then it will progress to endothelial injury. Whenever endothelium is injured, can I say it will take into account and cause the virtuous triad? Endothelial damage is one of the important components of the virtuous triad, right? So this endothelial injury will automatically move the patient into a procoagulant state. right? It will cause a procoagulant state. Fine, because you can write also here activation of the virtuous triad. Not just that, automatically the bacteria also can directly cause an endothelial damage. By default, you'll have activation of the procoagulant state, right? Pro-inflammatory cytokines can also cause that. Direct activation of my coagulation cascade, right? So this will result in increased clot formation inside the vessels. So we call it intravascular coagulation. What's the term? It has to have the term DIC. This will cause disseminated intravascular coagulation. That's like more clot formation, consumption of the clot, bleeding. So it's going to be a very, very risky problem, right? So this clot formation will block the vessels and might cause ischemia related damage to the vessels. It could cause ischemia related damage to the adrenal gland, Waterhouse-Friderichsen syndrome, right? Ischemia related damage can happen to any organ throughout the body, can cause a splenic infarct, can cause a liver damage anywhere, even can cause stroke, right? Clot formation can cause that, right? Last but not least is you'll have a metabolic abnormality as well. Don't forget this. This also might be required, right? You'll have a metabolic abnormality. The problem with metabolic abnormality is it's not a direct cause of a damage, it's a feeder. It'll cause insulin resistance. So insulin resistance will result in increase in blood sugar, right? So increase in blood sugar, bacteria is going to be very happy, more activity. So again, it will activate the infection or be a complementary production to the infection, right? In addition to that, what happened to your because of the Waterhouse-Friderichsen syndrome, my glucocorticoid function might be gone. Complete destruction of adrenal gland, that will cause metabolic derangement, right? Lactic acid acidosis can also happen because of DAC, more of anaerobic glycolysis, and can end up in having lactic acidosis. These all will add on to the existing problem, right? So these four headings has to be there in pathogenesis: metabolic abnormality, procoagulant state, endothelial activation and injury, and also inflammatory counter-inflammatory response. If we can put after writing this, write in draw in a flow chart where all of them are interlinked. There's a beautiful flowchart in Robbins, in Ramdas Nayak, in Hashmogan, whatever book you follow, right? Everything is going to stem from Robbins only, right? That's what happens here, right? This is the pathogens of septic shock. Actually, if the question is on septic shock, you need not write about non-progressive compensated reversible phase, progressive irreversible phase, and completely irreversible phase. That is purely for your hemodynamic shock. It's not for septic shock. Septic shock, this should be more than enough for me, right? And then you talk about the pathogenesis. Lungs may, like you can talk about what happens in adrenal gland, you can talk about what happens in the heart, everything you can talk about that, right? If it's about septic shock, it should have clinical features. X, can you repeat that? Why? What do you mean by oncogenes are dominant and tumor suppressor genes are recessive? Can you tell me what is it? I'll definitely explain about that. Clinical features, definitely in high grade fever, obviously with chills and rigor. Because of lungs involvement, it will clinically present as an ARDS, where there'll be hypoxia, there'll be breathlessness, right? That will be there. And how do I confirm? Investigations, what I have to do. Apart from the routine investigations, CBC will have neutrophilia, extremes of neutrophilia might have shift to left, everything. You can write that. The most important thing for me for investigation is blood culture to prove there's actually an infection so that I can give the antibiotic appropriately, right? DIC related, look for the fibrinogen levels, look for the levels of PTA, PTT so that you can appropriately treat them, right? Obviously, I have to take the care of the oxygen saturation, look at the CT of the X-ray to see how worse the ARDS is and have to treat them, right? Treatment is starting with broad spectrum antibiotics, supportive treatment, then with the culture specific antibiotics, fine? Sorry. Okay, that's about septic shock in short, fine? See, Rishank, there is a stage of septic shock, right? So when, sorry, hypovolemic shock, based on your question. Initially, the reversible phase is when you are saying all the periphery become cold and clammy and I am saving my kidney, splanchnic circulation, heart and the brain. Let's say it goes to the next stage. These are the least important. Then comes the fight between kidney, heart and the brain. Which is least important? Kidney. That will go off. Then what happens? Heart and the brain. Final death. So based on the stage, obviously different structures gets involved. Initially kidney won't have a problem, but kidney is a problem which tells me that, okay, the shock is so severe, the vital structures are also getting affected. In that phase, I'm going to panic more because the outcome of the patient might not be great. Fine, Roshan? Great, Vinay. All the variables do well. Next, can you please repeat your question? I'll tell about that. Roshan, you asked me one more question. What is that? You are asked about hypertrophy, right? Cardiac hypertrophy. Right? Okay, that. Okay. I'll take about X question first. Okay, we have something called your Knutson's two-hit hypothesis, right? This is always a doubt. Knudsen two-hit hypothesis said that I need two allele mutation to cause cancer. Clear with this, X? Clear with this? Yeah, I'll take about necroptosis. Give me a second. I'll complete this and I'll take about necroptosis. Till this clear? Perfect. So now let's have an inherited disease. Fine. Inherited cancer syndrome. Let's take neurofibromatosis. It's an inherited cancer syndrome, right? Okay. So when this person is born, okay, they'll be born with one allele mutation. So this one allele mutation is inherited. They are born with that. Fine. Now answer me, X. I'm taking a disease of atherosclerosis. And there's a person with familial hypercholesterolemia, inherited problem. Is that alone enough for atherosclerosis, or I will also need hypertension, other problems also? Yes, to some extent, right? Only hypercholesterolemia, inherited, might cause atherosclerosis, but on top of that hypertension, eating a lot, smoking a lot will cause accelerated damage, right? Is that true? To some extent true, right? Let's take one more disease. I'm having a patient with an ADPKD, autosomal dominant polycystic kidney disease, which causes renal failure. Let's assume it causes renal failure generally 40 years. But this patient who has hypertensive very early, diabetic from 30 years, will the renal failure be early or late? Will be early, right? So now ADPKD as well as your atherosclerosis related hypercholesterolemias, all these are genetic. We accept that it's a dominant disorder, right? Because whatever extra coming are sporadic risk factors, but they are born with only one mutation, be it ADPKD or be it your hypercholesterolemia. The same way, this person is born with one mutation. I will decide the inheritance based on what I am born with, not what I get on the go. So the second mutation which causes cancer, this is acquired. It is not what this person is born with. Let's assume for a fact, neurofibromatosis person never had the second mutation, no cancer at all. FAP person never had the second mutation, no cancer at all. Retinoblastoma person never had the second mutation, no cancer at all. So tell me whether this is inherited or acquired. Purely acquired, right? So I cannot tell, okay, there are two allele mutations, so it's recessive. That's your question, right? Two allele mutation causing a disease is recessive. But when both the allele are inherited, otherwise I don't call it a recessive. Here only one allele is inherited. So now what I'll say is one allele mutation is enough to cause a disease. When one allele mutation is enough to cause a disease, I call it dominant. So everything here has to be dominant. The other allele mutation is acquired. Don't take it into inheritance. That's why I say that almost every cancer syndrome is of dominant inheritance because rest everything is undoubtedly acquired. Fine. Imagine X, your dad has given you 10 lakh rupees inheritance. You earn 10 lakh rupees. Will you put that also your dad contribution or your contribution? Your contribution, right? That's not inheritance. That's your savings or your earning. Like that, this is acquired, not inherited. So we'll take inheritance only based on this, never based on this, because acquired. It might happen, might not happen, right? Okay. That's why almost every cancer syndrome is due to one allele mutation at birth. So it is dominant. Can be autosomal dominant or an X-linked dominant. Fine. Okay, X. You understood or confused you more? Okay, perfect. Okay, Rishan, your question of necroptosis. Let's go to your question. Necroptosis, na simple one. It's in the name, right, Rishan? You've been with me for the entire year. You should destroy pathology, okay? Necroptosis, necrosis plus apoptosis. So, pathogenesis is simple. It starts with an extrinsic feature of apoptosis, which means, okay, had an FAS, FAS ligand interaction, then I had FADD. This FADD actually activated caspase. But what happened was there are few viruses which are very clever. COVID is clever. Every virus is clever. They can modify, right? Just give me a second. My iPad got switched off. You. 1 second, guys. I hope it turns on. I'll connect it. Okay. Audible? Sorry. Can you hear me? I hope you can hear me now. Dun, 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 dun. Audible? Okay, so what I was saying is, I'll come back from first. So when FAS ligand binds to each other, the FADD is stopped by few of the viruses using few enzymes. So I had an alternate pathway to escape. So a complex called as RIP complex comes, which takes from FADD and activates few molecule called as MLKL. So MLKL will form a complex, multiple MLKL protein, which will drill holes in the cell membrane. So something which started as an apoptosis from FADD but ends up in cell membrane damage. That is necrosis. So we call them necroptosis. That's the pathogenesis. Few examples for necroptosis. Virus is where we started with viral hepatitis, especially cytomegalovirus. Steatohepatitis, necroptosis. Also one physiological mechanism when in your uh, the growth of the plate, the human growth plate, the fusion also is based on necroptosis, right? And also few of the neurodegenerative disorders and inflammatory bowel disease is also based on necroptosis. These are few examples of necroptosis. Clear, Ishak? Okay, rib complex is what converts from one place to the other place. Fine. Vinay, clinical pathology part, I'm not sure how much in depth they will ask. They might ask urine examination, talk about albumin in nephrotic syndrome. You know about your microscopy of the renal calculi, right? Talk about that, that's enough. I don't think they'll ask about semen analysis to you. That's not much important for an undergraduate. Apart from that, they might ask pap smear. We have read about pap smear. That might come in a clinical pathology part. very, very less importance clinical pathology part. Fine. See, Rishan, what I said was I'm not, see, if you take a hypovolemic shock, right, there's a non-progressive phase. We call it a compensated or a reversible phase. Then you have a progressive phase. It's progressing, but it's still not irreversible. The last is my irreversible phase. Non-progressive phase, kidney is normal. Progressive phase, kidney gets a hit, but still heart and brain is normal. Irreversible phase, that also is going to go for a toss. We have three stages in hypovolemic shock, and that's how we divide hypovolemic shock. Right? Okay. Fine. Anything else you want me to talk about? Let me know. If not, let's call it a day. Okay. Okay, guys, this is my last class of Farre. We'll be closing with for this year. But like I said before, we'll be reading more and more pathology and medicine together. Go well, perform well, you studied well. Presentation is the key. Unfortunately, in a theory exam, it's fine. You'll do well. If not, don't worry. You have the knowledge. You can take care of medicine at any point of time, right? All the very best from my side. And thank you for your patient time. And I hope you guys will make sure the future of medicine is in right hands. Fine. That's the goal. Honors distinction pass is not the goal. NEET PG is not the goal. Medicine will be in right hands, and I hope we'll do that. Fine. Same here. Yes, Rujang. What in chronic disease? Chronic DIC. Chronic DIC or in chronic disease? See, Rishank, it's not about I can make it or not. If the trigger no is happening daily in chronic cases, my blood vessel is so vast. Imagine my hand, just for a hand. So many blood vessel, so many endothelium. I'm hitting here every, like in a day, I'm hitting 4 5 places. Consumes. So chronically it will be deficient because the etiology is ongoing. That's why I'm not able to replace to an amount what my body is consuming. That's a problem in chronic DAC. Fine. Okay, guys, that's it for today. Thank you. Thank you for your time and all the very best. Do well. Yeah. You asked for this, no? I missed it. So let's say heart. Fine. So you have a heart. One is pressure overload, right? One is volume overload. The volume overload is where we have the aortic regurgitation and all those things, more blood volume. Pressure overload is where hypertension is, right? It's pressure. Let's take this is a chamber of my heart. Can I say increased blood pressure will exert the same outcome everywhere? Yes, Rishan. But volume, regurgitation. Volume always goes to the most dependent part. It will exert more pressure down, not on the top. That's what liquid does. And pressure, atmospheric pressure is same whether you're in Kashmir or in Kanyakumari. It's the same. It will not change. Whether in USA or here, pressure is always equally distributed. So when it's equally distributed pressure, I'm pushing this part same way I'm pushing this part. So both the parts respond in the same way. Since it's equally distributed pressure, the hypertrophy will also be equal across the walls, which means it is throughout. If this is my cross section, I'll add pressure all over, and my hypertrophy also will be equally distributed. That's why we call it concentric hypertrophy. Here, it'll be thick, but what happens? This part alone will be more thick. It's an eccentric hypertrophy because the push was more in the below part, right? It's your physiology, no? more stretch, you stretch a muscle more, it will more contract. You stretch a muscle less, it will less contract. That's how hypertrophy also works. Fine. Okay. Perfect, Shashank. Great. Doubts done? All the very best, Shashank. Do well. Everyone who's there, do well. All the very best. See you soon. Hopefully, after your exams, let's see if we can do something for your practicals. We have recorded. Hope that comes soon for your practicals. Fine. Bye bye. Thank you.